It's an honor and a pleasure for me to be here. This is a new forum for me. I'm usually more on the clinical side of things when up on the podium, but happy to be here and hopefully able to kind of share some more of my clinical experience to any of those who are administrators out there. Just a standard disclaimer slide. So I just wanted to start with giving you a little bit of a background for my clinical practice, my training. I had the opportunity and fortunate pleasure to be able to train at some of the top institutions across the country. Did my residency training at Johns Hopkins Hospital in Baltimore, and then probably my favorite year of training, though, was my one-year fellowship in sports medicine in Vail, Colorado. And the gentleman up here on your upper right is one of my mentors, close to my heart, Dr. Philippon, who's one who really turned me on into my particular interest, which became the focus of my practice initially, which is hip arthroscopy. And then that has gradually transitioned into a practice of anterior total hip arthroplasty over the last 5 or 6 years of my practice. So I think my clinical practice is somewhat unique in that it's really made up almost completely of either hip arthroscopy or total hip arthroplasty. And over time, I've been able to transition these types of cases almost exclusively to outpatient centers. So I'm doing about 75 or 80% even of my total hip arthroplasties as an outpatients now instead of doing the procedures at a hospital setting. So I joined the Grand Rapids Surgical Suites, which is in Grand Rapids in 2017, initially doing primarily hip arthroscopy procedures there, but then about a year later started doing some of the anterior hip replacements, which was actually kind of new in our area at that time. I know it's been done longer in like Chicago or some of the other metropolitan areas, but that's continued to grow over the last few years. And then wanted to give you a little bit more background specifically about the surgical center itself. So our center is it's a 2-room, 2 OR, 1 procedure room. So for a total of 3 rooms, it's made up of multi-specialty group. So there's 4 orthopedic providers, 3 of us who do incorporate total joint arthroplasty. I do the anterior approach. I have a partner who does posterior approach, total hip, as well as total knee or partial knee replacements. The center itself occupies a footprint of about 7,800 square feet with a total of 8 pre/post-op beds that are used interchangeably. Just to kind of pull the audience here, how many of you are in a CON state? You know what that means, so maybe about a third or so. So Michigan, I'm from Michigan, which is a CON state, and did provide kind of an initial hurdle in terms of getting authorization to open a center. And if people have questions about that, particularly in the Q&A section, happy to kind of talk more in depth about that. But that was an experience where we had to document that the surgeons coming to the center had what they call an excess number of cases that they would plan on bringing to that center before getting the validation to be able to open a room. So the way we planned, the way that center was planned was they built it out for a 2 or 3 room footprint with only opening 1 room initially. So we got the CON for the first room, and then about a year later was able to accumulate enough cases where we were able to open up the second room. And then we do not need a CON for the procedure room. My personal total joint experience, so I started in my practice bringing the total hip arthroplasties to the center at about 2018. As I mentioned, I do exclusively anterior total hip, which I think has an advantage for an ambulatory center, but my partner does posterior approach. He does a great job and has had a lot of success there, so they don't necessarily need to be done from an anterior approach. But between myself and my 2 partners, historically, we've been doing about 100 total joint arthroplasties at the center a year, although I think this year that number is going to be higher for reasons that we'll get into a little bit more later in the talk. And then in addition, I do about 100 hip arthroscopy procedures at that center each year. And if you're a facilities manager or working at the center, what I would consider to be the must-haves to be able to perform these procedures, especially like a DAA total hip, would be the Hana Table, a fluoroscopic unit, And then kind of a tertiary item would be intraoperative monitor to be able to pull up intraoperative x-rays, because that's really a kind of a paramount part of particularly the total joint replacements. And then having a second assistant is quite helpful as well, just due to the retractor needs that are put on from the total joint perspective. My protocols, I'll break these down into preoperative, day of surgery, and then postoperative. I think really the big part, a huge part really, of having a successful outpatient total joint experience is, number one, patient selection, which is done on the surgeon side, as well as education that can be done both from the surgeon's office, but also from the ambulatory facility as well. And a huge part of this going into it is, the patient's state of mind and preparing them just to know, hey, you're going to go home. I think you're healthy enough. I think you're going to do well. This is something that we've done, consistently with success. And so patients are motivated. They have more buy-in to their surgery because they know they're going to be going home and going to be relying on themselves and family or friends, and not necessarily hospital staff or nursing to kind of walk them through. So I think I've seen patients just kind of delve in more. They're really interested in, going through their preoperative books. We do not have a dedicated class that they go to at our center, but we do provide them with, a fairly comprehensive booklet and encourage them to review that prior to the day of surgery. I also provide a script or a prescription for them to get a walker before the surgery. So I do not impose any range of motion precautions. So for instance, patients do not have a 90-degree sitting rule or anything like that after the surgery. And they are almost always just allowed to put all their weight on it right away. But I tell them their job when they're up and around is not to fall, particularly in that early recovery period, because an early fall is really a way to mess this up. So I want to make sure that they have the walker available. And then I also encourage them and give them a script to have one physical therapy visit prior to the day of surgery to make sure the walker is fitted appropriately and they know how to use the walker for transitions and stairs and that kind of thing, because I don't want people showing up to surgery being like, well, I don't have a walker, I don't know how to use it. It's really not the nurse's job or within their expertise to be fitting walkers and teaching them crutch or walker training. And then the day of surgery, we do kind of typical things with HIPAA wipes, nasal swabs, and then from pain control perspective, in the pre-op area, about an hour, 45 minutes before the surgery, I use 2 grams of oral TXA, tranexamic acid. I give 1 gram of Tylenol, 5 of Valium, 10 of OxyContin, just for preoperative pain medications. And then we don't routinely use Emend. It tends to be expensive. And if the center doesn't have it, the physician's offices can provide a prescription to the patient to get from a local pharmacy. But if patients have a history of postoperative nausea, this can be really key in getting them out in the recovery room in a timely manner so they're not just lingering there feeling nauseous, because that can end up being the rate-limiting step. And then intraoperatively, I've really transitioned to using almost general anesthesia for all these patients, although we've also had success with a midpivocaine spinal, which is a little bit shorter acting than a typical bupivacaine spinal. So the duration of action of the midpivocaine is usually about 2 hours, where bupivacaine would be more like 3 hours. And then I do not do any formal blocks, but we do this local multimodal analgesia kind of in the deep tissue around the surgery area. This REC is a proprietary product that we use, but prior to that, I was just using a combination of similar medications that can be injected. But the downside of using a formal block, such as a femoral nerve block, is that it can knock out the quad muscle, and so that you can get a fall. So I've really moved away from doing any kind of formal femoral nerve blocks. And then typically patients are going home 2 to 3 hours after their surgery. And I used to really favor more at-home healthcare, where the provider would come to the patient's home, although as we've had more experience with this, I've become more comfortable with patients just doing outpatient PT starting a day or 2 after their surgery. And then I want to talk a little bit about why I like using the DAA approach, or direct anterior surgical approach, for total hip arthroplasty. And mentally, I break this down into patient factors and surgeon factors. So when patients come to me because they've done some research and are asking about DAA, they're already aware of a lot of these things. But the literature supported overall when we're looking at hospital lengths of stay, the length of stay is shorter for the DAA. And I think really that has to do with less soft tissue trauma. So it's an intramuscular approach, meaning we're not having to cut across the gluteus maximus, which is the big butt muscle. I do tell patients I have to retract against these muscles, you're going to be sore, but we're not having to cut across any of those muscle groups. So they generally have a little bit less pain, more functionality, and particularly in that first 2 to 3 weeks of their recovery, but allows them to get out of the center more quickly. And frequently we'll see these patients walking out of the center like carrying their walker instead of using it. I'm like, no, just put it down on the ground. We don't want you to fall. But surgical incisions tend to be a little bit shorter, and like we talked about, and then lower dislocation rate. So I don't know if this is wooden, but I've done about 500 now of these DA total hips. I have not had a patient dislocate. I tell them it can happen. You don't want to go do yoga the day after surgery, but I do not impose any formal range of motion precautions. So that's a big factor for patients, because once they've signed up for a total hip, they go talking to other people, they start hearing all the horror stories of what can happen, and I think most people end up hearing about somebody who's had a big complication like a dislocation. But more importantly, from my perspective, I think the DA approach is helpful because I can really dial in the cup position, which has favorable long-term benefits, particularly if you don't want like eccentric wear of the liners, and it also helps prevent hip instability or dislocation. So the combination of using the Hana Table and fluoroscopy, I get to look at that, where the implants are, where the trial implants are first, and then double check it once the definitive implants are in there. So I get to know I'm leaving the OR with all the implants exactly where we want them to be. And it also allows me to really dial in their leg length. So I use like an alignment rod to compare their operative versus non-operative hips, because leg length inequality is the #1 reason for a lawsuit after total hip replacement. So we pay really close attention to making sure their leg lengths are right where we want them to be. And then one other thing that we do is just we can move that hip all around. So we put in the trial implants, we're moving the hip all around, make sure that ball's not starting to slip out of the hip socket area. And so when I started doing hip arthroscopies in 2010, I was using the Hana Table, and I was doing about 300, 350 hip arthroscopies on the Hana Table a year. And so transitioning to the DA approach using the Hana Table is really a natural transition for me. But it was actually designed more for DA than hip arthroscopy. And so it was extremely well suited for that. Some of the things that I really like about it are just the freedom that allows me to move the leg. So I talked a little bit already about maintaining hip stability, but it also has a femoral lift in it. It's right here. It's a little bit hard to see, but I think this is key when we're working on the stem aspect of the implants, because it does two things. It lifts the proximal femur, the proximal part of the leg, up more into the surgical field, which is really the most challenging part of this case from a technical perspective. And then secondarily, it also provides nice counter pressure. So when we're broaching, we're impacting implants down in the femur. That femur's not just going wiggling up and down on me. So I know I'm getting consistent counter pressure on that patient. So that helps, I think, prevent proximal femur fractures as we're broaching or trialing. And then the table's radiolucent. One of the challenges frequently in a surgery center, particularly when you have a multi-specialty group, is storage space is at a premium. It's non-revenue generating space. You want to try to keep your footprint as small as possible, but all these different specialties want different equipment and different tables. And I think as tables go, the Hana Table can take up a smaller footprint. It can kind of lift up a little bit here to try to take up less space. And it's also something that patients are aware of. I've had several patients come and ask me specifically, "Hey, do you use the Hana Table for this surgery?" So I think that's it's at least perceived as kind of a higher end piece of specialized equipment that they want. This is a bird's eye view here of what a general setup would look like. So we have the patient, myself. I actually have a PA too that starts up here, and then kind of a non-skilled assistant. Really could be almost anybody that frequently holds like a retractor throughout much of the case on the other side of the table. And then we'll usually just do like one large back table and then a kind of semi-portable Mayo stand there. So these are images of one of my actual setups. Super easy setup. I use like a 10-15 drape here and then a 10-10 drape, but this is the surgical field, that proximal thigh. And then a small padded perineal post there. This is the next layer with like a shower curtain. So there's really only 2 layers of draping. You can see it's super quick and easy. And then I'll just throw a towel over there, and I frequently set retractors there when we're going in and out with fluoro. I use surgical hoods mostly just to protect myself from splashback. I think it's more surgeon preference than anything. I've tried to get my trays down. We're down to 3 trays now, unless I have to do something a little bit unusual. But we have a great scrub tech. They lay out everything. So this is the Mayo. This is kind of the main instrument tray here. This is like that femoral hook. I call it the femoral hook or S hook that goes on the back side of the femur, and then kind of a bridge attachment for it. And then these are just trials and reamers. But this is really it from like a instrument perspective in terms of what we use. And like I was saying earlier in the introduction, the number of patients that I'm able to do and that feel comfortable transitioning to outpatient total joint replacement it was growing gradually before 2020, but then with COVID, it's really grown, I'd say, exponentially. And that's twofold. I mean, I think in our community, people are becoming more familiar with it. There's more word of mouth as more and more people have positive experience with it. But, I also have patients now just flat out saying, I don't want to go to the hospital anymore. Like, they don't feel safe going to a hospital setting. From a data reporting aspect, there's a little bit lower risk of an infection with an ambulatory center, which makes sense. You just have fewer touch points with each patient, and it's less cost. So if as a center provider, if you're curious about what your local hospital system may be charging a patient for total hip, you can ask a surgeon maybe who has a good relationship with a patient to share their EOB with you, and then that can give you some negotiating information if you're working with third-party payers. But also, there's just much more of a concierge experience. So, a patient comes in, there's much fewer people talking to them, potentially touch points, and it's just a much more tailored experience. From my perspective, I love doing my cases at our surgery center. We have much more consistent staff. It's time-wise much more efficient. Our turnover times are 25, 30 minutes, even for a big case like a total hip, as opposed to our hospital, which is consistently an hour turnover time. And then from a surgeon perspective, there's opportunity for gain sharing and then marketing. So if we're looking specifically at growing your service line, OSI has a lot of resources here that I encourage you to look at. They have a marketing kit, a smart start kit, and ways to try to figure out what your return on investment on a table would be. As a surgeon, I've done a community talk trying to just build presence. I don't do a lot on social media, but I know other people have had a lot of success doing that. And then things that you can promote from a technological perspective are, the DAA Approach, Hana Table, and more recently, robotic assisted surgery is gaining a lot of traction. Just kind of a final slide here, and takeaway points. Keys to a successful orthopedic arthroplasty program is just really surgeon and center collaboration, right? Patients don't have a surgery at your center because of the center. They have surgery there because the surgeon recommends it or brings it to them. So having that close relationship with them is really going to drive success. Because it is usually a mutually beneficial opportunity for both of you. And then patient education and then follow-up, so having nurses contact the patients day after surgery, check on them, particularly for a large procedure like a total hip arthroplasty. And then for third-party negotiations, surgeons can be a part of this, or if you're part of a larger ASC group, you can kind of work within sister centers to try to negotiate better contracts. And I think particularly when you're looking at expensive implants like total joint implants, having the surgeons involved who have those relationships with those companies, because those companies do not want to jeopardize the surgeon using them for a little bit of a decreased cost. And one final thing here, so the volume sterilizer. So the center did have to change out one of our sterilizers because it could only fit like 4 trays. And so when you're getting into these cases with ortho or spine, where each case has potentially 4 to 6 trays, you want to make sure that your sterilizers can be able to turn that over, particularly if you're doing 3-4 cases a day.